society. I would like to call upon stage our eminent judges to judge our program today. Dr. Debashish Bhattacharya, Dr. Mohan Rajan, Dr. Shugata Paul, and Dr. Madhu Bhadoria. And Dr. Sunita Dubey. Both of them are probably out. We have 5 teams today, 5 teams from 5 states. We have Kerala team here, we have Jharkhand team, we have Orissa along with us, we have Tamil Nadu, and the other one is Haryana. I would like to call upon stage Dr. Doel Biswas to take the teams forward. Thank you so much.
So without much ado, we'll get on because we are a little short on time. Let me tell you the orders of the team. First, we have the Kerala Royals. Can the team members of Kerala Royals stand up? Huge applause for them, please. Next, we have from Orissa, the Kalinga Viranganas. And then we have the Haryana Hurricanes to blow us all away. Haryana Hurricanes, where are you? Make some noise. Then, and as I pronounce the next name, please pardon me if I pronounce it wrong because I have my tongue all twisted. Senthamis Nattu Tamizaki. Okay.
Senthamil Nadu Tamizhachiye.
Senthamil Nattu Tamizhachi.
If I was ragging you, I would have Dr. Fairuz pronounce that. And last but not the least, the powerful team, the Steel Starlets from Jharkhand. And now, may I call upon the team captain of Kerala Royals to come forward and introduce her team? To come forward and call upon all her team members on stage and then to start the video.
Good morning, respected judges and my dear colleagues and the beautiful host members. A very warm welcome to here our magnificent ladies of Kerala Royals. I welcome Dr. Meena Chakravarti, the inspiring lady, and please give them a warm welcome. And my players, Dr. Rakhi, Dr. Laila Mohan, and Dr. Natasha for the mentor-mentee session. And my other teammates, players are Dr. Sandhya, Dr. Meena CK, and Dr. Fairuz. So, kindly play the intro video for the Kerala Royals.
Can we start?
Yes. Okay. Your time starts.
Can you switch off the lights?
A huge round of applause for Kerala team.
So the first presentation is by myself, I am Dr. Anita Jabbar from Little Flower Hospital, Angamali.
Good morning. The story begins when a 33-year-old male was referred to me for laser vision correction. He had high refractive error. On taking detailed history, patient had sensory neural deafness, also an end-stage renal disease, and the patient was on dialysis following a failed renal transplant. There was also a family history of affected female sibling. His corneal topography showed no ectasia in both the eyes. Slit lamp showed posterior polymorphous dystrophy, oil droplet sign, and conical protrusion of the anterior lens capsule. Both retina had asymptomatic retinal flex. Thus, he was a known case of Alport syndrome. The story of my patient teaches us that before a surgical decision, take a detailed history, thorough systemic evaluation, audiometry, and nephro consultation, especially in anterior lenticonus. Alport syndrome is a rare condition that affects the kidneys, inner ear, and the eyes. First described by Cecil Alport in 1927, and in affected families, male members are more severely affected. COL4, alpha 5, and 2 other genes are found to cause Alport syndrome. These 3 genes are essential to form chains of the protein collagen 4. Faulty gene causes defective trimer, and this trimer is found only in the kidney filter, the inner ear, and the eye, the exact same places affected by Alport syndrome. Lenticonus develops by conical protrusion of the lens from the weakest and the thinnest part of the capsule. Our patient underwent uneventful phacoemulsification with IOL, and the histopathology showed a thinned out capsule. What to remember in anterior lenticonus? Lens capsule is highly elastic and thin, and more prone to tear towards the periphery. So frequent grasping and re-grasping of the capsule is essential to optimally size the rhexis. Thank you.
So I'm Dr. Aki De Cruz, and I'll be presenting the next case from Team Kerala Royals. So I'm going to tell you a story actually. It's going to be a story of a mysterious beauty. एक लड़की थी दीवानी सी, एक लड़के पे वो मरती थी, पर आजकल उसको देखने के लिए इसके आगे ठीक नहीं दिख रही थी. Please play. Play, please. So this beauty walked into our OPD complaining of blurring of vision for near and distance for the past 1 week. So her main issue was she was unable to see her boyfriend clearly for the past 1 week. This beauty had a dark history. She was a known case of sickle cell disease, and she had a recent history of COVID and was admitted in ICU. Her visual acuity was 20/40 in the right eye, 21/25 in the left eye. Rest of the examination was actually normal. Fundus showed a grayish lesion surrounding the fovea. Also in the left eye, there was this grayish round-like lesion surrounding the fovea with irregular borders. So we went ahead and did an OCT, and the OCT showed hyperreflective band-like lesions involving the outer plexiform layer and the inner nuclear layer. OCTA also showed few signal void areas, especially in the deep capillary slabs. FFA did not show any leakage. Thus, our diagnosis was paracentral acute middle maculopathy. PAM, as we know, especially involves the deep retinal capillary system, impaired blood flow occurs, and the anatomical and the physiological watershed zone is particularly affected. COVID started involving the retina with conjunctivitis, and later the retina also with multiple cases of NFL infarcts, and also had this hyperreflective lesions in the inner plexiform layer. We further investigated our case and found that the D-dimer level was increased. She was sent back to the physician and started on injection enoxaparin and steroids. So in our case, she had hypoxia because of the lung involvement due to COVID, along with the sickling status and the high D-dimer level, which finally led to the PAM lesion. She was started on enoxaparin and Visalon, and on review, her D-dimer level became normal and the PAM lesions also resolved.
Now her vision is 20/20. She can see her boyfriend clearly and sincerely. Thank you.
Can we go to the next? Yeah. Hi, gorgeous ladies and smart gentlemen. So I love gold and I love jewelry. So what I'm going to show you here is how an oculoplastic surgeon like me uses gold in my practice. This is a very novel technique which is called the posterior lamella micro incision technique.
Just increase the mic volume, please.
Yeah. So this is the video. Just one point, ek chutki sona in the eyelid, okay? And this is a very, very nice hidden technique which I really love. I never used to do gold earlier because of the complication. This is like a posterior lamella technique where you can hide, and this, trust me, it's just 10 minute surgery. So this is a very small incision which is taken in the tarsal side, very close to the tarsus. You go and dissect it and you make a pocket. You make a pocket, a lateral pocket and a medial pocket. If you have seen, I have taken a medial 1/3 incision in the tarsus. That is because I'll tell you how to insert the gold. So a very small pocket medially. So the entire length, the maximum length of the gold goes into the lateral pocket. And you have to really stay close to the tarsus, not even the peritarsal tissue, and then very easily slide it into. So all the complication of extrusion, etc., in the anterior lamella approach can be avoided in this approach, and it's just 10 minutes. I would say less than 10 minutes. And we insert it. It's not actually sutured. It joins in, and this is how the results are. So this is a very novel technique, and after I learned this technique, I started using gold in my practice. Otherwise, I was never fond of the thing. I used to do LPS recession in all these patients, and this is the, I could have put more pictures, more explanation, but to the limited 2 minutes time, this is my series of patients who have done wonderfully well with this gold technique. Thank you so much.
A very warm good morning to all of you. I am Dr. Sandhya.
This was a traumatic subluxated cataract, and you can see folds on the posterior capsule. Only very little trypan blue was injected to prevent escape of dye into the vitreous. Around 180 degree of zonual dialysis became obvious. Triamcinolone was injected to look for any vitreous in the anterior chamber, and none was present. As the rhexis was initiated, the entire back lens complex started moving. Viscoat was used to plug the area of dialysis, and a capsule hook was inserted to support the rhexis where it was done. As I was losing control over the rhexis, a microrhexis forceps was used. 3 capsule hooks were used to support the area of dialysis. After a good hydrodissection, OVD was injected under the rhexis margin, and a CTR was inserted in a manner not to increase the extent of dialysis. CTR gives equatorial support to the capsular bag. Since the cataract was very soft, I could not split it, so it was prolapsed, and a supracapsular emulsification was done after protecting endothelium with dispersive OVD. Low aspiration flow rate was used to minimize the chamber turbulence, and before withdrawing the phaco probe, OVD was injected into the anterior chamber. Cortex was removed by pulling it tangentially rather than radially, and the 3 capsule hooks were removed carefully. This much extent of dialysis was not obvious even on lying down preoperatively, so I was not prepared with a sutured CTR. So a 3-piece lens was inserted, and the 2 haptics were placed over the rhexis margin in the area of intact zonules. The optic was captured under the rhexis. CTR gave equatorial support to the capsular bag, and the 2 haptics in the area of intact zonules gave extra anchorage to the intraocular lens. Since the optic was captured, this will prevent future migration of lens through the area of dialysis. Once constricted, there was denting of iris, and an anterior vitrectomy was done. At the end, pupil was round, and this was 5 days post-op.
Thank you.
Good morning, everyone. I'm Dr. Meena CK. We have two Meenas, and I'm Dr. Meena CK. The OOPS movement, I'm talking about a one-year-old child who came to us with total cataract, and you can see the corneal diameter is almost normal. And we were expecting a complicated cataract, and you can see how the anterior capsule is behaving. And it was not yielding to the cystotome or to the capsule forceps, and a vitreous or a micro scissors is being used here to to make an opening in the anterior capsule, and it was quite fibrotic. The anterior capsule is getting removed, and we were expecting a complicated cataract and also a PHPV since it was a unilateral one, and it was a normal B scan. So, see, this is the OOPS movement. It looks just like a retina. You can see the pattern of the vessels. It looks just like the branching of the retinal vessels, and I was a little apprehensive. Called our guardian angels, retinal surgeons from the next theater, and they too came, and they too were a little apprehensive what to do. So we just closed it down. Then the next day we repeated our B scan, and with the help of our retinal surgeon, again we posted the next day, and we were now almost sure that's not the retina, but still little apprehensive. And we opened up that thick membrane, and it was a very vascular PHPV, but usually in PHPV it will be the center part that is involved, but here the total posterior capsule was involved, and there was no view, no red glow, so it was little apprehensive because you can't take off the retina. So with the help of the retinal surgeon, the capsule is being cut. You can see it's just like a eggshell, and we had to use the endocautery because of the very high vascularity of the capsule, and endocautery is being used here along with a pars plana vitrectomy, and here you can see that fold, but there was a fold of retina too in it, so we couldn't cut that PHPV, a total PHPV. Thank you all.
Next, I call upon Dr. Meena Chakravarti, madam, for her inspirational talk.
Excuse
her introduction?
Just.
That's okay, ma'am. That's okay.
So we are going to complete with each team first so that it becomes easy to mark. Next, we have the mentor-mentee, where
We need two mics. Meena CK.
This is the mentor-mentee role play. Just give us some time for them to set it up. Yeah. They are being judged too.
Good morning, ma'am. May I come in?
Hello, good morning. It's a long time since I saw you, Natasha. How are you doing?
I'm okay, ma'am. I didn't want to trouble you too much.
How is your surgery going on?
I'm very low and down, ma'am. I don't think I can become a cataract surgeon. I just had too many complications, ma'am. The scleral tunnel I had a problem with in one case. The next case I had a PC rent, and my instructor got so angry with me, and I'm compromising patient care, and I just feel so bad. I'm just going to
Natasha.
leave this course and go, ma'am.
That is how we all learned. We all learn from our mistakes, and that is how we learn. You don't learn on one fine morning. So, have you seen your videos?
No, ma'am, I couldn't bring myself to see it. It's just too traumatic. I just want to go from here. I don't think
Come
I
on,
can do
Natasha.
it.
Don't worry. We have all had our own mistakes. We have learned from them. And the most important thing is to identify
But
what...
ma'am, you're such a good surgeon. I'm sure you did beginning
I'm sure
itself.
from mistakes you learn, and you will become a fine surgeon in future. But definitely you have to know where you have gone wrong. For identifying your problem is the most important. And then you definitely rectify it after seeing it again and again. So I can sit with you and see where you have gone wrong.
Oh, that would be so nice, ma'am. Then I'll face it if you'll sit with me.
Definitely, why not? I have made this, not this mistake, I have made more blunders and learned from my teachers, the best teachers in our, in India, and I have learned from them.
I've been trying the capsulorhexis on tomato and grape. They don't give you that feel. I don't know.
Of course, you have to learn from a wet lab or.
We don't have a wet lab.
Nowadays, I can arrange a slot with my friend.
Oh, that would be
With
so
a
nice.
virtual surgical simulator. They are very easily available now, and you can learn from them.
Okay, ma'am.
And definitely, I am sure you will make us proud by becoming a great cataract
I
surgeon.
feel so relieved after talking to you. I feel so relieved. With you by my side, I'm sure I can become a good surgeon
I'm
someday.
sure you will do well.
I think that was wonderfully played out. And that brings us to the end of the marking session for the Kerala Royals.
I would like
Now-
to introduce
Now, as we know, this entire program is all about woman power. And believe me, today at least, this is the only hall that has the presence of both beauty and brains residing in the same hall. All the other halls have either beauty or brains. This has beauty and brains together. So I call upon, now the next program we are having, we have one of these inspiring ladies from each team coming up here and speaking, saying a few words, presenting a case, whatever she does. And Shudipta is going to introduce the ladies.
Well, I would like to welcome on stage Dr. Meena Chakravarti. Big round of applause for ma'am. Dr. Meena completed her undergraduation and post-graduation from Trivandrum Medical College. She completed her DNB and fellowship in the medical and surgical diseases of retina and vitreous from Arvind Eye Hospital, Madurai. Slide, please. Presently, she is a senior consultant at the Chakravarti Eye Care Center, Trivandrum. She has done her observership in posterior segment diseases at various centers of renown in USA, Stephens Eye Research Institute, Bascom Palmer Institute, Wilmer Eye Institute, John Hopkins, Wills Eye Hospital, and Jules Stein Eye Institute. She is the winner of several international and national awards for paper and poster presentations. She is the recipient of the National Award for Prevention of Blindness instituted by NSPB for the year 2007 for her work in preventing blindness due to diabetic retinopathy. She has authored chapters in several textbooks. She is the editor of the Kerala Journal of Ophthalmology, the official publication of KSOS for a tenure spanning 4 years. Chairman of the Scientific Committee of KSOS 2014 to 2015 and President of the course 2019 to 2020. Please welcome on stage Dr. Meena Chakravarti and a big round of applause for her.
Thank you, friends. Good morning to all. At the outset, I'd like to thank my home team for selecting me as the inspiring lady to represent them. And I have titled my talk, A Tribute to the Woman Surgeon. It's a tribute to each and every one of you sitting here. We have reasons to be proud. In August 2023, there were 2 very significant articles published in JAMA Surgery, which was a tribute to each one of us. It said that we are better surgeons, our patients did better, they had better postoperative results, and we wielded the scalpel much better than our male counterparts. This is something that we have to be proud of, considering the fact that I have mentioned here some of the terms that has been talked about women surgeons when I went through my junior residency and internship. And from that, we have evolved into a breed that is disciplined, hardworking. We follow the set established guidelines. We never ever cut corners. We take fewer risks in the theater, and most of all, we are able to innovate. I would like to share with you a small innovation in my own field, which has been a boon. which has been a boon to perimenopausal women who have macular holes, who usually have macular holes, and this does not need the prone positioning that is advocated for 4 to 6 weeks after surgery. This is called the macular plug technique, and it has been published in Retina in 2017, and it won me the Best Video Award at the American Academy of Ophthalmology. This shows the internal limiting membrane being peeled. Even if you don't have the hinge at the edge of the macular hole, you can still get away with this technique because we are going to plug the hole with a 3-layered plug. The first layer is the autologous blood taken from the patient himself. The second layer is the peeled internal limiting membrane, and the third layer is again another layer of autologous blood, which ensures that the plug remains in space. There is in place in the well of the hole. There is no fluid air exchange. There is no gas or air tamponade. The procedure is shorter. There is no prone positioning in the postoperative period. And this has been a boon, especially to the women who develop macular holes. And I thank you very much for your patient hearing. I thank the Women Ophthalmological Society and also my home team.
May I call upon the Jharkhand team to come on stage, please?
3 cheers for the Kerala team.
Jharkhand
Hip,
team
hip,
led by
hooray.
Dr. Kashyap.
Thank you all, and thank you, judges, and best of luck for the whole program.
Jharkhand team captain, Dr. Bharti Keshav.
So good morning, brilliant ladies and bold gentlemen. Here is the team Jharkhand Steel Starlets. So myself, Dr. Bharti Kashyap, I am the captain of this team, and our 5 presenters are Dr. Archana Kumari, will be presenting retina case, Dr. Nidhi Gatkar, she will be presenting cornea case, Dr. Richa Gupta will be presenting anterior segment complication management, Dr. Ritvija Grover will be presenting an oculoplasty case, Dr. Prabha Chaurya will be presenting a strabismus, unique strabismus case. And the inspirational talk will be by myself, and the mentor-mentee role play will be done by Dr. Monica Jathani and Dr. Priyanka Sudani. So now I am giving an introduction of the team, the video.
Kindly maintain your time, 20 minutes for each team.
So never underestimate
the power of a filler. It's not just an extra. So this is the kahani of this dulhania who was about to get married. So she took a selfie and she said, "How can I look like this for my marriage?" She said, "What do I do? Let me go on Google. Let me search." So she went on Google and she found my name. And she decided to come to see me. So I saw that she had upper lid retraction secondary to her thyroid eye disease. And I wondered, it's too close to the wedding. What do I do? Let me put in a filler as a spacer in the upper lid. So we proceeded to evaluate her upper lid, and we found that there was not too much tightness because of the eyelid retraction, and we decided to put a filler subconjunctivally. You can see there that we are palpating just below the tarsal plate, and the filler goes in very smoothly. In this case, we've put a high viscosity filler, that is Voluma by Juvederm Allergan. I have no financial interest. And what we've done is, once we put the filler in, we sort of just massage it out so that there are no nodules created because it's a high volume filler. And as you keep putting the filler, you can check how it looks cosmetically. And you can see her lid retraction was corrected. So she was all ready for her wedding, and she was happy with the symmetry that she got. And she finally got married, and we can do a nice surgery for her later on.
So, Tersan trouble. So, this is about a 22-year-old male who presented with cerebral artery rupture aneurysm and was treated medically, but here he had left eye Tersan syndrome hand movement with RAPD. The surgeons were very speculative about the results. So, we did a core vitrectomy, and the skytic membranes of the vitreous were removed. Then a beautiful PVD here you see is done, which made the task bit easy, but there we can now see the posterior pole with a big subhyaloid hemorrhage, which was left untouched, and along superiotemporal arcade, there was a lobulated elevation. So after doing the core vitrectomy, the 360-degree peripheral vitrectomy, I attempted to remove this subhyaloid hemorrhage, which is flushed off the macula. The lucky boy, after removing the hemorrhage and doing fluid gas exchange, the macula was very clear and could be seen to be healthy. But now we had to tackle this superior lobulated lesion. So, with the help of ILM forceps and the cutter, the lesion was tossed and tucked, and finally, that area could also be cleaned, which is seen as a reddish area in the superiotemporal part. And then there was a small break along the doing these revelations of the layers. And then finally the break was lasered and the eye was closed under silicone oil, which was removed 1 month later. Final BCVA after 6 months was 6/9, and this is the lucky patient. So the take-home message is clearing Tersan's BH can be rewarding in any time span, even with the poor prognostic markers like RAPD.
Respected judges and the gorgeous ladies, a very good morning to you. So we all have witnessed the passionate love story of Jack and Rose, who met on the Titanic. But Jack ended up at the bottom of the North Atlantic Ocean. What if we rewrote the story and ended it differently? Let's see how. So this was our Titanic, a large PCR and a dangling nucleus. While doing anterior vitrectomy, it sank down into the vitreous. After cortical cleanup, the back looked clean and scrubbed. Vitreous was cleared around the lens and PFCL injected. Slowly and steadily, the bubble filled up the globe, pushing the nucleus up, and now it was within our scope. Phacoprobe was inserted without the sleeve to emulsify the nucleus. PFCL was removed completely, leaving behind no mess. Then carefully in the sulcus, a 3-piece lens was placed. All the wounds were sutured, no port left unsecured. The post-op result was excellent, simply miraculous. And that is exactly how we rescued Jack and his love story. So Rose and Jack got united, got married, and lived happily ever after. Do let me know if you like this ending better than the original one. Thank you so much.
Good morning, everyone. We are presenting a tale of one muscle yet many deviations. A 7-year-old girl came with deviation in her right eye, exodeviation, and 15 PD hypertropia. On detailed history, was it always like that? No. On detailed history, we found that it was infantile esotropia and status post-squint surgery at the age of 1 year. And then it landed up into consecutive exotropia and hypertropia with concomitants. Then on ASOCT, we found faint hypointense layer about 10.56 meter away. The plan was medial rectus exploration with advancement and inferior rectus plication. But on exploration, only muscle sheath was found without muscle fiber. So it was a case of slipped muscle MR. We have lost MR muscle. Now what? There is no muscle fibers. We have confirmed. Now next plan B, because child is under GA, inferior rectus was isolated and was transposed to the presumed side of medial rectus in view of exotropia and hypertropia. So pre-op first one, day 1 post-op, almost aligned and improvement in adduction as well. Search, if not found, replace it. Thank you so much.
T-sec triple in a vascularized cornea. This patient presented with DOV after a surgical procedure. BCVA was 1/60 with IOP of 12. There was a phakic corneal decompensation with vascularization. A surgical iridectomy could be seen, but there was no bleb. The angles appeared open and the disc was normal. The other eye also had open angles with normal disc and IOP. I planned a T-sec triple. But there was florid vascularization with very poor visibility to go ahead with the surgery. However, a full thickness graft would not survive in this case. So, an endo-illuminator was used to give better visualization and the cataract could be removed. And the IOL was placed in bag. Decimet membrane was cored and removed in toto. And the tissue was manually dissected and inserted. only started after the graft insertion, as the poor visibility obscured the view. The graft was crumpled, which was slowly ironed out, and air tamponade was given. However, the large iridectomy caused the air bubble to repeatedly move into the posterior chamber, pushing the iris towards the graft and causing inadequate tamponade. What should I do? Slow decompression of the anterior chamber caused the air bubble to come up, and with adequate tamponade, the graft attachment was confirmed by endoline. The graft was attached on post-op day 1. The vascularization started progressively resolving over time and almost completely regressed by 1 year with a BCVA of 6/12 and normal IOP. Thank you.
So my question still remains, why was the primary procedure done? Why was the surgical PI done? And there were no OT notes, and I still don't know. Thank you.
Role play, please. Mentor-mentee, we are lacking in time.
We'll do it here. We'll do it here.
Okay.
Please play.
Wherever you're comfortable.
Just flap your wings together and we'll meet you at the top.
Good morning, ma'am.
Good morning, Dr. Priyanka.
Today I have a task to do. I have to make a LASIK flap. So please help me and guide me because you are an experienced surgeon.
Definitely I will. So, flap making is very easy. Just be cautious of few things. Keep few things in mind. Always mark your cornea and always check your ring size. It should be on the basis of keratometry and white to white. And always check your vacuum. If you check your vacuum, you will not land up into complications.
Okay. Thank you, ma'am. Now I think I can perform the surgery.
Oh, great.
So, oh, it's a free flap now. What to do? I'm in a fix. Please call the mentor, please.
Hello, Dr. Priyanka.
I'm in a fix. I have a free flap. What to do? Please guide me.
Don't worry, that's okay. It happens, and free flap is not a very big complication. It can be easily handled. Just, you did your marking, right?
Yes, ma'am.
Oh, that's nice. So take care of the marking and always remember to know which is the epithelial side and which is the stromal side. Epithelial side will be smooth and stromal side will be rough, and stromal side will enroll. Okay? So do the laser and preserve your flap first in the saline, and do the laser and place it back and place a BCL.
Okay, I'll do the same thing, ma'am. I will place a BCL now. Ma'am, my patient has got 6/6 vision. Thank you, ma'am. आपने बचा लिया मुझे आज. I will never forget this learning experience throughout my life.
I am so happy for you. You are such a good student. You did it.
But what if it was a bad mentor-mentee relationship? Oh, free flap. Please call the mentor.
What these people don't understand, they keep calling at any time. We don't have any private life.
Oh, ma'am. My patient has poor vision. Refractive surgeries are not my piece of cake.
What if one woman stands for another?
The whole world changes.
Thank you.
Next, we have Dr. Bharti Kashyap speaking.
I would like to ask Dr. Bharti Kashyap to kindly give her talk.
So myself, Captain Team Steel Starlet, giving a small pearl of inspiration, Road to Pinnacle. Women play an integral role in the framework of the family. Early in her life, she is very much involved in achieving her career goal like her male counterpart. Soon comes the challenge of matrimony, and as a young, obedient ophthalmologist's daughter, she accepts it and takes it in her stride. But then comes the challenge of indecisiveness of whether she should do a fellowship or she should prioritize to start a family. This is an undebatable point that she should first expose herself to the fellowship with a good exposure of surgery, and then she can start a family with a well-decent, well-earned break. There are more crossroads, eternally bridging bridges between the family, children, and the career pool. A moment of redundancy should not set in to realize later that her lifetime ambition has not been realized. You only see obstacle when you take your eyes off the goal. Growth has to be a constant process, a slow, steady climb by taking things in small measures to remain relevant to the profession. No sense to win over trivial issues in the family for the big battle and the victory and the final goal in the question. Rather being just rungs of the ladder for others to build their success stories. Should not she have enough courage to dream a pinnacle for herself? And what would be the business model galore for this late starter? Small fellowships with good surgical exposures, and then she can dream of a level playing field coming in later in her life. Business models that are galore are there. Does she perceive herself in solo venture if it is an underserved area and she thinks that she will click easily? Group practice, if the small boats appear rocky, don't board it. Climb the stairs with your senior partners. Government setup, yes, it should not be a primary healthcare center type. Corporate base, okay, be it a standalone hospital or a corporate chain. Maybe make yourself indispensable. Establish your stand, work tirelessly, gain prominence, move to sharing a small share in business, incentivize growth and a risk-free life. Acquire your management skill, whatever gets thrown in. Partake in conferences are very important, and to have some podium presence. You should stand out from the crowd, regular communication, prompt response, dedication, growing relationship, taking initiative, promoting professional development, developing leadership quality. Fear is your feeling and courage is your decision. Never compare yourself with your male colleagues. Everyone is unique. This woman is a winner. She has taken diverse paths. You watch this woman, don't challenge her. She has challenged herself at various segments of her life, has made families her own. She will rise up slowly towards a pinnacle. She is versatile. It is up to you, women, what you want to be. Educate a man and you educate an individual. Educate a woman and you educate a family. Thank you.
Okay, women. Okay, women, the challenge before us now is to be as little late as we can. So let's try and keep that challenge and win that challenge. Come on, Haryana team, up on the stage and start your video.
हमारा वीडियो Good morning, ladies and gentlemen, the bold and beautiful and the women and the brave men here. We are Team Haryana, a state which is known for sports. We bring out the finest sports women. So no fancy words, no fancy dresses. We believe in action, so let the sports begin.
good morning, everybody. I am Dr. Deepa Gupta, and I'll be discussing a surgical management and challenge faced in a keratoconus case. So I had a 18-year-old female with the BCVA 2 meters, finger counting, and in such an advanced keratoconus, we cannot do anything. No intacts, no contact lenses. We had to resort to surgery, and so I did one eye, and the patient was very keen to get the other eye operated. So this is the second eye of the same patient. I'm performing a DALK. In this, I remove an anterior lamellar cap, and this is how a big bubble formation is being done to separate the Descemet's membrane from the rest of the cornea. And now I seem to have lost the plane, and I'm manually dissecting it till I get a bare DM. Yeah, so now I remove the Descemet's membrane of the host graft, and the cornea is sutured. I'm using a 80-year-old cornea because in this we already removed the endothelium, and the patient did very well, 6/12 post-op vision. But now look at the condition, patient is not at all happy. The parents are calling me that what have you done to our daughter? One eye is white and one eye is black. So I plan to take her up again. So I took the challenge and I took her up again for regraft, re-DLK. 3 weeks later of the first surgery, the sutures being dentally removed. You can see the Descemet's folds in the Descemet's membrane, and then I take another graft and replace it with the 50-year-old Codona cornea. The carefully resuturing was done, and finally I'm able to get away with it. I put my ear with a 30G cannula in the end, and finally the patient was very happy. She's doing very well, 6'9", and now I have a almost 5-year follow-up with her, and so this is it. Thank you.
Good morning, everybody. I'm Dr. Anita Sethi, and I'm going to describe how teamwork can, how we can do it together. A difficult case of a choroidal melanoma, and we used a lot of teamwork to do this case. A 31-year-old presented with decreased vision, had a lightly colored, lightly pigmented mass close to disc and macula. So because there was SRF, the lesion was more than 3 millimeters, so it is a choroidal melanoma. And then we have to now decide on what treatment should be done. So we confirmed our diagnosis. We see the elevated lesion is 3.31 millimeters, and we decide to treat because up to 40% of the small choroidal melanomas will metastasize, so they need to be treated. We did a ruthenium plaque, indigenous plaque. And the good thing about ruthenium is it is beta radiation, so it is a very limited radiation to only the tumor. In our case, we needed it to be there for 76 hours. So we took the patient up for plaque insertion. We prepare the area, and we actually first use a dummy plaque with no radiation, and we anchor it to the sclera. And then we do an indirect to make sure that the plaque is centered nicely over the tumor. And once we are absolutely certain of the position, we then take out the actual plaque, which is stored in its radioactive container. The inner surface has the active site, so you don't touch that. We then insert the plaque in, and with our pre-placed sutures, we close the conjunctiva. Patient is kept in the hospital for the 76 hours, and then we remove the plaque. At the time of plaque removal, we give an anti-VEGF injection to limit the doses of the radiation retinopathy. So we can see how with a very big team, we can solve a very difficult case. And some of the people who helped are from Kerala and sitting right over here. Feroz, thanks for your help.
Good afternoon, everybody. I'm Dr. Saiba Sethi, and here goes my case. So this is my story. A one-eyed patient, CF at 1 meter vision, 60 millimeters of mercury on Dimox for almost 2 months. Cut open conjunctiva, sclera, an SICS scar is there, which was almost the top 100 degrees. Also multiple sclerostomy ports. Now, if you don't give a glaucoma surgeon even conjunctiva and sclera, what are they going to work with in such an advanced case of glaucoma? Trab was not an option. But like a sportswoman never gives up, what I thought was taking an Ahmed clear path and folding the flexible silicone plate in the shape of a taco is something that I can still try with the whatever leftover conjunctiva that I have. So it also, another advantage of this valveless device is that it's got a proline suture, so you can see how there's just a 3 millimeters of conjunctival opening through which the valve is folded and then reopened once the insertion has been done, and then is being secured in place. The tube is being placed in the sulcus since this is a pseudophakic patient. So now you can see that in between the two sclerostomy ports and the SICS scar, I had only limited conjunctiva to work with. Even an AGV or an ADI implant would have been a little dangerous in this case, leading to exposures, bleb leaks. You can see how easily the conjunctiva with just 3 interrupted sutures can be closed. Very good post-operative outcomes. And also at the end of you can see the graft is well placed. At the end of 2 months, the rib cord is also being removed to increase the flow through the lumen, and the patient's IOP is 16 millimeters on 2 AGMs. So it's always important to re-strategize in any difficult situation and find whatever you can do with whatever is given to you. Thank you so much.
A very good morning to everyone. Perseverance can turn obstacles into opportunities. By knowing the appropriate technique, one can achieve victory. I'm very excited to present this case of a one-eyed old lady who had progressive corneal decompensation because of a long-standing iris claw ACIOL. The biggest hurdle in this case was to explant this ACIOL atraumatically so that you can implant another IOL and top it up with a DSEC. So we went on with a routine way of entering the eye with the main port and side ports. And while removing or explanting the ACIOL, we made sure to use the right technique. We gently pushed the iris backwards from the haptic clip and then carefully did it on the opposite side and ultimately explanted the iris claw ACIOL. We then inserted a new iris clip IOL with a phakic IOL design. Again, focus on technique here is very, very important. We gently used the mid-peripheral iris, pushed it backwards, and ensured an appropriate enclavation on both the sides. Having a dimple on both sides is a good way to ensure that it is done well. This was then topped up with a DSEC where the endothelium was removed and a donor lenticule was implanted inside by placing the DSEC lenticule carefully on a blob of sodium hyaluronate. After this, we ensured that the AC was well formed, gave a tight air fill, ensured a good centration, and the surgery was completed. The patient did really well. She was very happy and independent once again. So basically what I want to say is that, volume please. So perseverance can ultimately lead to victory. Perseverance, perseverance, and perseverance is the main thing for all of us, whether it's a surgeon or a sports player or any other field. Thank you so much.
I'm feeling so proud as a captain. Teammates, you're doing really well. And we are not wasting time. Judges, please note that. So I'm going to be talking about 2 cases of subluxated cataracts, 2 different scenarios, and how our sportsman spirit acts in the OT as well, and our resilience and our perseverance and our ability to practice and keep ready helps us out. So this is a case where you will see that the subluxation is for more than 4 clock hours. I do a careful CCC, careful hydro procedures, and I have my bag hooked up. This is a slow-mo phaco. We keep all the fluidics low, and I have my cataract done. I'm doing a slow IA, and I'm stabilizing my bag with the capsular tension ring. All in all, everything is going well. So while I have my cataract out and my bag is still stable, I'm planning a Ahmed segment valve now to stabilize the bag. So I go ahead and plan with Gore-Tex suture. So I straighten both the curved needles which come on the Gore-Tex. First one needle, strapped it into the segment, and I have put this segment into the bag. The first railroading is happening pretty smoothly. You can see here how the first is out. Now, in my second needle, this is where the complication begins, because when I try to straighten it, it is not straight. And I'm struggling, and I'm struggling, and I'm struggling. I have hyphema. It's an edited video, but trust me, it took me more than half an hour here to get my needle out, and I thought probably I'll have to abandon the case somewhere in between. So perseverance paid, and I tried, and I finally got the needle out. I had my back stable. I had a stable lens. The patient did very well. The second case, the subluxation here is more than 180 degree. I had to use at least 3 hooks to stabilize the bag. Again, a slow phaco, very careful, very gentle fluidics. There was sometimes chemosis in between. Drained the new fluid to have better visibility. Did not lose my cool. Kept doing the IA, though it was getting entangled with the capsular hook. Now, I thought I have done well, and I'll be able to get away like the previous case, but here I have a large tear. So now I have a subluxated bag, unstable, and I have a large PC tear. Again, our sportsman's rib. We don't get nervous in the OT just like that. I had all lenses prepared, so I had a scleral glue, I had a 3-piece prepared, and I had an iris claw. So what do I do here is, with a large PC tear, I take off my capsular hook. Now, looking at the scenario, I chose to do iris claw by stretching of the pupil, mechanical pupilloplasty. I bring it down, enlarge my wound, and use an iris claw. So enclave it on one side. Luckily, the vitreous didn't come out. We were prepared for anterior vitrectomy as well with my VR surgeon as a backup. We enclaved it on both these sides, change of hand to do the other side. Now remember, this is an open wound. We are not only cataract surgeons, but we are bothered about cataract refractive surgery, so suture it properly. This is post-op 1 day, and this is post-op day. So the patient ultimately, volume please, did very, very well. And I think as a team, we have shown you a potpourri of covering all the cases right from cornea till the posterior segment. So truly, resilience and team spirit had worked for our team very, very, very well. Thank you so much. So we'll move on to the role play. And I would invite my team. And it's a very important message that we are carrying here. So please be with us.
Now please get up and get on to work. Chalo, chalo, utho, utho, get up.
Sister, it's 11, more than 11. Where are the doctors? Oh, madam has come. Sister, what is the time? Can you get some tea or coffee? What would you like to have, ma'am? So what is going on? Who is going to fill the discharges? Yeah? What kind of attitude is this? See, if you have to not, I mean, you can't waste a seat, right?
Okay, now do your case. Start your case. Shh. Another complication. I am just sick of this girl. ये लड़की जिंदगी में कुछ नहीं कर सकती. I'm sorry, ma'am. I would not be able to supervise her any longer.
Saiba, Dr. Saiba? How are you, beta? What happened? No, I've noticed that for the past few months you've not been yourself. Are you okay? So, you know, it's very important to talk. It's okay not to be okay. So, have you spoken to anybody? Have you spoken to any of your colleagues? Tell me what's happening with you.
So, ma'am, I just don't seem to focus. I am having trouble getting out of bed. And I've been having complications every time. I have no friends. There is a lot of pressure. I'm the only doctor in my family, and I just cannot handle this pressure anymore.
No, I understand, and I hear you. We've heard from your mother also that you're having difficulty, getting up. But it's important to talk, because once we know, then only we can help you. So tell me, are you sleeping okay? Are you eating properly? Are you able to make decisions? Are you having difficulty in OPD and OT concentrating? And what is this? Let me see this. Oh dear. Did you try to self-harm yourself? Have you ever had suicidal thoughts during this journey? Be honest about it.
I do, ma'am. Nothing seems to be working right for me, and I don't see that there is any point of me being here and embarrassing everybody, whether it's my seniors or my family. I'm sorry, but I just cannot handle this.
It's okay. You know what you're going through? You're not able to help it because this is not sadness. You may be having issues which we'll talk about. We need to get help. First tell me, do you want to feel okay? Do you want to get out of this situation?
I do, ma'am. I've tried, but I just cannot get myself to be motivated enough to do it on my own, and I have absolutely no support.
So see, this is the best part, and your battle is already half won because you are motivated to help yourself. You understand what the problem is. So let's get professional help. Let's talk to your inner circle friends, rope in some colleagues, okay? We'll talk to your mother also, and we'll be on a journey ahead. So we start from here. We take you out of this situation. Even if we have to take medicines, it's not a taboo. It will help you feel better. Once you stabilize with some psychotherapy, and then I'll help you to work on your surgical career. So are we all together in this? Yes, great, come. A few years later, so she's worked on herself, she's went to a clinical help. There is no taboo. Highly functional medical doctors could be having mental health problems. It strikes out of the blue. You may be the best person on the earth, but you will never know mental health strikes you. So no taboo over there. There is no shying. Please share your thoughts with people. Seek professional help. And that's the role of a mentor and mentee. It goes beyond hospital, beyond surgeries. Thank you. Thank you.
I would like to welcome on stage Professor M. Vanti for her inspiring talk.
Put it up, please. Yeah, I think I'll just run you through. As a woman, you'll need to balance both your work and family so well, and also take care of your physical, mental, and your emotional quotients and keep them in the right proportions here. So what you need and how would you go through all this and carve your niche where you need to be here. So just my 10 pearls on this is all big things have humble beginnings. All things start small and you can still make it big here. Know your weaknesses and your strengths. It's not just your strengths. Work on your strengths and make yourself stronger, but work on your weaknesses and know where you have to draw your limits here. Again, do not be afraid to do more work to climb the ladder here. Convert every negativity in the situation you're being put in into positivity. That will work you towards your success here. Your quality of work reflects in your commitment to work. So when you love your work, you do not have to work at all here. If you want something, remember, you will have to earn it. There are no free lunches in life here. And next, what is most important, that discover the challenges, discover the potentials within you to overcome your challenges here, and you are your own competition, and be a better self than what you were yesterday. So that makes you the best competition you will have to face here. Be honest with yourself. You do not need anybody to look at you and to validate you. What you have to compete with is your procrastination, your ego, your unhealthy eating habits, your neglecting knowledge, negative behaviors, and the lack of creativity. Nurture these and know what not to do. If you have to nurture, if you have to grow in life, let no one set boundaries for you. And that you will be able to carve your niche in your society here. So what you will need is, as a woman, shine just not today, but every day. Thank you.
Thank you so much, everybody. We were Team Haryana. We believed.
We would like to
Dr.
call upon
Vanathi,
stage the next team, please. We are running a bit late.
No. So we just wanted to end saying that she believed she could, so she did. Thank you.
Welcome on stage, Team Orissa.
Good morning, all you wonderful ladies and gentlemen. A big namaste to the woman in you. Every woman that holds another woman's hand is a woman, and every man that stands behind a woman is a man. So good morning, all. Without much ado, let us start on the video. That's the introductory video. This is from the land of Lord Jagannath.
Life, a complex and stunning masterpiece crafted from perfect balance of 5 essential elements: earth, water, fire, air, and space. The human body is also the product of these 5 elements in different proportions. The interplay of these elements plays a crucial role in sustaining the harmony and balance within the human body and also the eye. In the intricate dance of 5 elements, disruptions can spark disorders. The artful use of element earth representing resilient cornea to delicate retina, surgical use of gases, dyes, and laser symbolizing air, water, and fire are crucial for ocular care. Clear eye space is sacred, ensuring success and embodying the nature of space. To unravel the essence of these 5 elements, we present the valiant Kalinga Viranganas. Dr. Smruti Priyadarshini stands strong, rooted in determination, representing the element earth. Flowing like a tide, powerful and serene, our graceful Virangana Dr. Sangamitra Kanungo will represent the element water. Powerful, Dr. Shweta Patro burns fiercely, unstoppable in her passion. Agile Virangana Dr. Devi Aishwarya Das moves swiftly, strategic and elusive, embodying the essence of air. Mysterious Dr. Sarmista Behra harnesses unseen powers, mystical and enigmatic, representing space. When all the elements are in sync, it creates a synergy that's beyond individual significance, empowering individuals to engage in visionary and inspiring work that uplifts the moral and supports those in need. With unwavering courage, the inspiring Dr. Sujata Das leads with grace and strength. The mentor, the empowering Dr. Pragya Panda guides with wisdom and compassion. Resilient Virangana Dr. C.K. Deepa faces challenges heads-on, emerging stronger with each hurdle. Now, brace yourselves for the wonderful presentations.
Very good morning. As the earth is essential, the element earth is essential for the survival of life. The limbal stem cells are equally important for the regeneration of the cornea. A young male presented to our OPD with accidental fall of pan or tuna 3 days ago. We can see that there's a diffuse corneal haze, there was limbal ischemia, and there was chunks of tuna particles in the fornix. A diagnosis of limbal stem cell deficiency was made. So limbal stem cell deficiency can have varied clinical presentation and there are various causes. So we planned EDTA chelation and amniotic membrane grafting in the case, and later we decided to go for a simple limbal epithelial transplantation after 6 months. So this is the donor, this is the healthy tissue from where we healthy cornea from where we harvested conjunctival and limbal autograft from the superior quadrant of the unaffected eye. This was followed by, in the affected eye, we did a 360-degree dissection, conjunctival peritomy, followed by dissection of the pannus. Preoperative AIOC helps in knowing the healthiness of the underlying stroma and the residual thickness. This is done very thoroughly till the limbus. The autograft which was taken is now divided into 2 parts and secured at the limbus with fibrin and thrombin glue. A large amniotic membrane graft is put over it. And the limbal autograft which was taken is now divided into 6 to 8 pieces and secured over the amniotic membrane, and finally a BCL is placed. So these are the post-operative day 1 and day 8 photos, and we can see that the cornea had already started becoming clearer than the preoperative stage. Another similar story where there was a bilateral limbal stem cell deficiency where we did allogenic slit in one of the eye with a very good outcome. So SLED is a good option in unilateral and bilateral limbal stem cell deficiency with a wet ocular surface and a relatively clear cornea. Thank you.
Good morning, the beautiful ladies here. I'm going to play a video of a failed macular hole, a large failed macular hole. This was a 40-year-old female who was operated with a large, that was a failed macular hole, about 1,150. Please put on the sound. So I did a brilliant blue staining and then scraped the ILM. ILM was scraped. After that, I have put PFCL and tried to nudge the flap over the macular hole. I tried all sorts, the flap that was running out, I tried to put it, but it was a small PFCL. Every time I was trying to nudge the flap over the macular hole, it was coming out. So what to do next? Then I put some more PFCL to increase the bubble size. After that, I could easily nudge the flap, ILM flap, and cover the large macular hole. I increased the flap area also, completely covered the large macular hole. After that, did a fluid air exchange and a C3F8 injection.
We need to rush a bit for the next session to start.
Yeah, this was the large macular hole that was there, and this is the closed macular hole, and my day went very good. Thank you all.
Fire, when used responsibly and appropriately, can create nothing less than a magic. In ophthalmology, we use thermal energy from lasers to diathermy in a wide variety of conditions, ranging from PDR, DME, RVO, ROP, glaucoma, and even in the treatment of tumors. So, despite advancements, we sometimes run out of options when we become creative. So this is a case where when we want to do a complete retinectomy and in areas of shallow SRF, it is difficult to cut the retina. So we use high power diathermy, which makes the retina contracted and friable and makes it easier for the cutter to find a plane and complete the procedure completely without much injury to the choroid. It can also be used as a surgical tool where we dig the diathermy probe into the nucleus and then hold it and levitate it into the anterior chamber. Besides being used as surgical tool, we can also use it in laser, as in this interesting case of a 40-year-old male who presented with persistent pain and redness. His best corrected visual acuity was 618, and he had anterior chamber reaction with vitreous cells and haze. There were intraretinal ill-defined lesions, and in this part, that is the infratemporal quadrant, we saw something wriggling. And when we had a closer view, we found there was a small worm. So what next? We waged a war against it and then fired some shots and killed it. And that was the POD 7, and this is 1 month. And that's how we won the war. Thank you.
Now coming to air. As soon as you hear the word air, who comes to mind? Hawa, Hawaii. So now let's see what fun this Miss Hawa, Hawaii can do. So we have this compression sutures with intracameral gas for acute high drops. And then in a PDEC, creating a type 1 bubble for making the PDEC graft. It's so well controlled. any age donor cornea can be used. An additional 10 microns from the Duas layer is added to just a DMEC graft. It makes graft handling much easier than in a DMEC. And then the PDEC procedure itself. So you see how well controlled air how a well-controlled air bubble can help you do a Descemet stripping and then unfold a PDEC graft. So you can strip a Descemet's membrane with above an air bubble, and then the same air can be used to unroll the PDEC graft. Now, just when you thought that you know the mind of a woman, this is how an air bubble can behave. So you have some of those oops movement trying to create the big bubble, and then you can see what happens. Not that you can always control a woman. So just like that, she can do a Mary Marzi movement on me. Thank you.
So just as Chandrayaan exploring space seeks to unlock the mysteries of the universe, medical advancement in orbital space holds the promise of understanding ocular tumors. These are orbital spaces which has to be known by all the residents. Now this is a 38-year-old male who came with axial proptosis and showing Knapfziger's view, and the A scan, the B scan was normal. Then you can see the अब क्या करना है?
हमेशा सुना है कि सिर्फ एक डॉक्टर ही है.
Then the ophthalmologist, we planned for a lateral orbitotomy, and this is a bony window being prepared by Jugaad. We took the oscillating drill from the ENT surgeons, and the cryodissection is being done. And then a firm purplish mass oblong in size of 20, 15, 18 mm was excised. And the lateral rectus was sutured back and the bony window closed. Canthoplasty being done. And then the histopathology showed a cavernous hemangioma, and this is a third post-op picture of the patient with normal ocular movements. And this is the pre and post-op picture of the patient. Thank you so much. Viranganas.
So the Odisha team, is it done?
Now the mentor-mentee program.
Yeah. Can we actually do away with that and go to the next session, because we are quite late actually.
Mentor-mentee, sir?
Okay.
This So this scenario involves a fellow who is struggling with managing her work-life balance and discusses this with her mentor during her mid-year performance review.
Dr. Deepa, are you okay? Since many days I find you disturbed in your work. See, the role of the mentor is not only to guide you in your academic achievements, but also to guide you as a whole, as a person, as a whole. Tell me, Deepa, are you okay?
No, ma'am, I'm not. Who would understand it better but you? You're a woman yourself. The biological clock ticks for us. Medic goes really fast. I couldn't delay it any further. Now that I'm a mom myself, I cannot really, I'm draining myself out, balancing the family and work. It's making life difficult for me. I feel like calling it quits.
Deepa, I understand it. You are my best student. You are my brightest student. Your contribution in the academic field is praiseworthy. What makes you so much depressed, Deepa? You can be frank with me.
Ma'am, I feel so guilty when I leave for work, leaving that little soul behind. I have absolutely no support. I don't know. I'm so anxious and worried all the time. I can't concentrate on my work.
See, Deepa, God has given this power of creation only to a woman. and God has made the women stronger also. So that is only, that is the best thing a woman can do.
We would like to
You
call
have to help
upon
me
our
out, ma'am.
inspiring lady. We would like to call upon Dr. Sujata Das to give her talk. Just take a minute, ma'am, so that the next team can get a chance to be on stage. We are running late.
Good morning. I'll be speaking on a topic which is started by ladies and run by ladies mostly. So I'll be talking about the journey of a eye bank in Odisha. So we started with the 2002 in a small setup. Now in 2007, Chief Minister inaugurated the eye bank in LB Prasad Eye Institute, Bhubaneswar. You can see the number. It took 1.5 years to get first cornea. So it remembers the perseverance of the staff founder that took time. So in 14 years, we collected 5,000 cornea, but in contrast, in 5 years, we collected 5 years. So now it is in top 10 eye banks in the country, is the 8th rank. And if you see the numbers in the first decade and second decade, you can see 1334 to 10,664, you can calculate. So this is the distribution, what we do in Odisha and outside Odisha and within LBPI. The graph is reversed. It was 35% outside Odisha in first decade, but it is 61% outside the Odisha. It is not that LBPI has decreased, rather LBPI has increased, otherwise Odisha state has increased. So we started giving, so we get the cornea from the districts of, few of the districts from Odisha, and we stand almost all the states of Odisha. I can proudly say it starts from Kerala to Kanyakumari and from Gujarat to Assam. So the lamellar keratoplasty also has increased with time. You can see Harminder Dua, who inaugurated the pre-cut lab. So we supply pre-cut corneas to, so impact, it is not only the number, not only the infrastructure, for the patient, the impact is, you can see the one-eyed child who has a long life to live, you can see the happiness of the parents, otherwise you can't do anything. So 2002, the manpower, the founder people, you can see again the ladies, and now 2024, so this is the teamwork which requires commitment, hard work and follow through. Thank you.
Thank you everyone from Team Odisha.
I would like to welcome on stage our last team, Tamil Nadu. A big round of applause for Tamil Nadu. Welcome on stage, Captain Dr. Sugneshwari Ganeshan.
Can we skip the team video, please?
First the video, yeah.
So now since we are running out of time, I will start with
The
my
surgical
first
video, please.
Yeah. So the first thing will go, since we all know that this session only started late, so we are also running late. It's not our fault. So we start with our Tamil Nadu team. Here comes the team from Tamil Nadu. So here we have Dr. Subhashini Kalyaperumal from Zipmer. She is going to be presenting her video now.
This is the story of a young girl who was diagnosed with Rieger syndrome at 3 years of age. She had hypodontia with correctopia in both eyes. She was initially controlled on a single drug, but then we had to step up the treatment, and finally she was on maximum tolerable medical therapy, despite which the IOPs were high and funders showed 0.4 cupping with worsening correctopia. This is when we decided that we'll do a right trabeculectomy with mitomycin 0.2 milligram per ml for 2 minutes. But we were in for a surprise. Post-op day 1, the vision had dropped to 560. The child was terribly upset. The IOP was 6. The disc showed edema with retinal striae. So with poor vision, low IOP, deep AC, diffuse bleb and disc edema, we were wondering what it could be. So could it be snuff out? But then the funders showed only 0.4 cup Could it be overfiltration? But then the chamber was not shallow, and there were no choroidals, and there was no large bleb. So we made a diagnosis of early onset hypotonous maculopathy. We were waiting for the maculopathy to settle down and the vision to improve, but nothing happened. So at 3 weeks, as the child was very unhappy, we decided we would explore with the parents' consent, and we placed a scleral patch graft and sutured back the conjunctiva. The next day, dramatically the vision improved to 6/9, the IOP was 18, disc edema and striations to resolve within a week. So the cause for the early hypotonous maculopathy was low scleral rigidity. Judicious use of mitomycin in normal eyes and younger children is necessary. Thank you.
Thank you.
So the next on stage will be Dr. Vidya Hegde from Anapoya Medical College.
Good morning, everyone. I'm going to narrate the story.
Just 1 second, please.
Stop the timer.
We got the hall 15 minutes late. The president and the chairman scientific, we had a talk. Absolutely brilliant that the work that you do, and the ladies, and such beautiful presentations. We can't actually stop you and or close the session, so we will continue. That's what we've decided, and maybe this hall will get a little late. 45 minutes, but the Optos is the next sponsored session, and then Star Surgical, they will get their allotted 1 hour 15 minutes. So that's the decision. Yeah, we are amazed with the efforts
you have given to make your video.
Thank you so much. Thank you.
Thank you. Good morning, ladies and gentlemen. I'm going to narrate the story of a young 12-year-old boy who was residing in a hostel away from his parents and siblings. He came to us with complaints of seeing double images and a pattern in the left eye of 3 days duration. 3 months prior to this, he was diagnosed to have alternating esotropia with hypermetropia, for which he was prescribed spectacles. While he was being evaluated, his anterior segment and fundus was normal, and his vision on day 3 had dropped to 660 from 618, which was on the day 1. So we were evaluating him, and we did an MRI, which was found to be normal. As the vision had deteriorated, we did a VP study, which showed delayed latency and decreased amplitude, suggestive of retrobulbar neuritis. So he was administered IV methylprednisolone. After taking 2 doses of IV methylprednisolone, on day 5, he developed this picture, that is a spasm of near reflex with a vision of less than 6/60. He was holding his eye in, both his eyes in convergent position. So here the clinical findings were not correlating, and we thought of a non-organic cause. The psychiatrist was given a reference for this patient, and he was found to be diagnosed as a conversion disorder. During the counseling session, he came out with his personal problems, frequent absenteeism, and fear of failure in the exams, and he depicted this in the art form. He underwent multiple counseling sessions of psychotherapy, and on day 8, he recovered with orthophoric gaze and went home happily. So at times when there is unexplained rapid visual loss in a child, we may have to think of a non-organic cause, and it can pose a diagnostic dilemma requiring a multidisciplinary approach. So in this particular case, a few words of encouragement helped the child which was disheartened. Thank you.
So next on stage we have Dr. Anupama, who is going to be presenting her video, and she is also from Anapoya.
A very good morning to all. So this is a story of a 35-year-old lady who presented to us in 2011 with complaints of blurred vision, She was not a hypertensive or a diabetic. Her vision in the right eye was 6/6/18. And what we are seeing there is extensive hard exudates right there, which was responsible for 6/18 vision. We traced the origin of hard exudates to be an aneurysm in the retinal artery, and which was hidden by the hemorrhage, and we made a diagnosis of RAM, which was exudative in nature. She received multiple settings of laser to the aneurysm, and over a period of time, like you see in 2811, her vision was 6/18, the aneurysm was there, but gradually the size of the aneurysm went on regressing. Like in 2012, it was reduced, and her vision, though her vision was still maintained at 6/18, 2014, vision still remained at 6/18, but you could see that the aneurysm was shrinking gradually, and gradually her vision also improved to 6/9. Because the exudates in the macula reduced, but as the aneurysm started shrinking in size, the review of literature showed that patients with heavy exudates generally do not do well because of the exudate spill. Luckily for this lady, her vision improved to 6/9. 2023, her last visit, her vision had improved to 6/6. You can see the aneurysm had become fibrotic, though there were extensive exudates along the aneurysm. So probably the energy of light, that is laser, had changed the hemodynamics of aneurysm. So always look for the origin of hard exudates. Multiple sitting of laser would be required for treatment, and eyes with heavy exudates do have a good visual potential. Thank you.
So we have now on stage Dr. Mona Kurana from Shankar Netralaya, Chennai.
Good morning, everyone. We had stories, so how about a fairy tale? In an island far, far away, there was a beautiful couple who was blessed with an adorable girl. The mother looked into the child's eyes and saw something unusual, dark and cloudy. This is what she saw, and her mood also became dark and cloudy. But being a doctor, she knew she had to act fast, so she took the baby, took a flight, and came to us. And what we saw was both eyes aniridia with childhood glaucoma. Pressures were high, axial length was increased, more in the right eye. So left eye trabeculectomy MC was done. In the right eye, external trab, because I could see the canal, and trabeculectomy also was done. PAX gene mutation was noted. They could only come back after 4 months. The left eye cleared, but the right eye corneal haze persisted. IOPs were borderline, axial length had increased, and this was hazily seen. So I didn't take a chance. I did a retrab in the right eye, and post-operatively, the IOP was 10, and the axial length was stable. But to my dismay, the corneal haze continued to increase. It got me down, and when I saw this in the right eye, so I took the help of my cornea colleagues. I didn't give up, and we did ASOCT and found that along with the changes due to glaucoma in the cornea, there was some element of limbal stem cell deficiency also, which is associated with aniridia and has been reported. So penetrating keratoplasty with keratolimbal allograft was done. These are the IOP changes during the course of the management, as well as the axial length changes. And finally, we did have a reason to smile because the disc was stable, axial length was stable, and the IOP was normal. Of course, we know that the road ahead is really long. We will hold her hand and make sure that this little bud blossoms. Thank you very much.
So now we have with us Dr. Savitri from Stanley Medical College, Chennai.
Good morning, one and all. There was a 31-year-old patient was brought to the psychiatric department for loss of interest in work, excessive sleep, extrapyramidal symptoms, and defective vision. And he had past history of hospitalization for the similar complaints, and patient was treated with fluoxetine, and fluoxetine-induced dystonia was the differential diagnosis for the extrapyramidal symptoms, and fluoxetine was stopped. He was referred for ophthal examination, right eye complete ptosis and right eye RAPD, left eye was normal, other cranial nerves were normal, and extraocular movements, adduction, depression, and elevation were restricted, and abduction was normal. And examination of fundus showed right eye temporal pallor and left eye disc edema, and differentials were Foster Kennedy with Turner palsy and asymmetric AON. After 10 minutes, the RAPD improved and the extraocular movements also improved. The adduction, depression, elevation. So MRI brain showed a hyperintense lesion in the frontotemporal lobe with a mass effect, the glioblastoma multiforme. The diagnosis were Foster Kennedy syndrome secondary to glioblastoma multiforme was made. And what was puzzling was the cyclical Turner palsy, which persisted only for 10 minutes. And so congenital cyclical Turner palsy, these were the DDs. So this was the case, and we looked up the literature, and ptosis was due to the exhaustion of neurons and GABA activity and functional interruption of corticofibral fibers. And there were similar case histories, case reports reported. And take-home message is thorough neuroophthalmic examination is mandatory in all cases of behavioral disorders like depression and the eyes level eye. Thank you for patient listening.
Thank you so much.
So now we have next on stage the mentor-mentee concept, which is going to be by Dr. Rashmi Jain from Enapoya and Dr. Durga Priyadarshini. She is from Shankar Nethralaya, Chennai.
Just a minute, ma'am, and then we will go for the inspiring lady talk.
Hey Durga, please come here. What is this you're doing?
Hi, ma'am. I have so many things to do, and I'm just confused.
What is this, discharges? Are you ready with the abstract for the international conference, the seminar? So many things you have to do.
Yes, ma'am. I have so many things. Like I'm totally tensed and distracted when I start doing anything.
Okay, relax, Durga. Tell me what exactly is your problem?
Ma'am, I get tensed and distracted when I start doing anything, and
Okay.
even just say I have a seminar immediately now
Right.
on efferent pathway. Just the mention of a gaze palsy scares me like anything.
Okay, I understand what's the problem. I think all of you can relate to it. You know, Durga, what's your problem? You're procrastinating. You're trying to choose the easy thing that discharges and trying to get away with the things which are not so easy. The seminar, gaze palsy, definitely difficult. Abstract for an international conference, definitely difficult. I think I have some solution for you. Would you like to listen to that?
Is it? That'd be wonderful. I'm looking forward to it, ma'am.
Okay, so let me see if I can help you a little. I'll teach you two techniques. One is called as time blocking. Divide your day into blocks. Choose a time which is most productive, your golden hour. How will you do that? Keep a time log. See when you're most productive. Now you have blocks. Decide what would you like to do in each block. Okay? Now you have a block which says, I need to prepare for my academics. In that block, what are you going to do? Because you know, no matter what we want, these discharges are always going to be there. Can I ever do away with this discharge when I'm a PG? No, I can't. What is it that you need to do in your block time? Well, the next technique is called Pomodoro. It is about managing your time and fooling or tricking your brain. How do we do that? Well, read or do your work only for 25 minutes. Okay?
Wow.
Now, take a break for about 3 to 5 minutes.
Excellent.
Okay? Repeat the cycle 4 more times. How much time? 2 hours. That's all. You have worked for 2 hours without thinking what you're going to do. And before you know it, you would have accomplished so much. Does this sound okay to you?
This sounds doable, ma'am.
Ah, so this is what you are going to try. Would you like to come back to me after trying this technique?
Definitely.
Okay, so I think this is something you can try and come back to me. I'm always there for you as a mentor to teach you not just ophthalmology, but life skills, the skills which will make you a better professionals and manage your work well. Is that okay?
Definitely, ma'am. Thank you so much. I'm just very glad that you're my mentor who understands my problem and able to guide me through. Now I understand why they say Mata, Pita, Guru, Devam. Thank you so much,
I would
ma'am.
like to
I'm
call
so
upon
happy. Thank you so much.
Dr. Sugneshwari for her inspiring talk.
So now today I'm going to be presenting my journey from a human being to being human. And I'm proud to say that I have my mentor sitting straight in front of me, Dr. Rajiv Raman, with whom I have started my project. So this is the epidemiological work which we had done. So now what do I say? So we learned that we had to bridge a gap which was there. So we did the skill transfer training program to help the Indians who are in the rural areas. So we got hold of doctors who are in the rural areas and we trained them the art of management of diabetic retinopathy. And we gave them within 3 months' time, we trained them and then they were out to do the work. So now from there, moving on into the next work of oncology, the pioneers of the retinoblastoma, where from a teacher, I took the role of being a student to learn the finer nuances. I'm there. Now here is a patient who comes to me who is being diagnosed as a melanoma everywhere. Anybody seeing such a large pigmented tumor would always think this is a melanoma. But what did I do? So I did the MRI, the ultrasound, the UBM. What did I tell the patient? She was a crying family, 30-year-old patient coming to you with a diagnosis of a melanoma, and then subjecting her for radiation or enucleation was everybody's choice before I saw her. So, but when I saw her, I told her, no, you're not dealing with a tumor. Let's do what I have to do. So yes, the pathologist agreed with me. It was a benign lesion, and here is the success story. Not only this, we also ended up going to doing a humanitarian work in terms of COVID. So when you have to inspire in a way that everybody follows you. So my journey from human being to human. Thank you.
Thank you so much, all the teams, for being patient. Thank you, audience, for being with us. And thank you, AIOC, for giving us this extra time. I would request Dr. Debashish Bhattacharya to kindly do the honors for our inspiring lady. I would like to call upon stage Professor M. Vanati. Please come on stage.
And thank you. The only dumbfolded people were the judges here. So much of talent. Actually, today morning I was very excited that I had to judge the ladies. So, to judge these days is a very bad thing. But then to judge the ladies and their beautiful work, we couldn't actually stop. And I had to fight with the president and also the chairman scientific, chairperson scientific. And we could squeeze some time. But the next sponsored sessions of Optos and the star sessions will get their due time. So let us have a peaceful journey forwards. And I was absolutely mesmerized. All the judges, Professor Madhu will agree with me that she doesn't know whom to select. So, but somebody has to win because we see this lovely golden cup. So, Sudipta, please carry on.
Yes, I would like to call upon stage Dr. Sujata Das to please accept her plaque from Dr. Debashish Bhattacharya. Dr. Sujata Das, not there. Dr. Bharti Kasha, please come. Sir, Dr. Sugneshwari Ganeshan, please come on stage. Dr. Meena Chakravarti. Somebody else, please come on behalf. For Professor Vanati, somebody please come on stage and collect her prize. Dr. Sugneshwari. We will announce the best team after the calculations. We need to leave the hall for the next session.
We have calculated. Actually, it's basically tie between almost all the 5 teams in terms of video. What made the difference was the role play. Both Tamil Nadu and Haryana did very well, and the final award is going to Haryana team for the best team.
Haryana, please come on stage.
It's your role play which made the difference. Otherwise, it's basically tight in the video presentation.
Best team Haryana.
And again, best video presenters, we had 4.
All the presentations were excellent and the work also was great.
Yes, and it was very difficult. And the award for best presenter is going to Meena CK.
Oh. Dr. Meena CK, are you here? Okay, somebody collect on her behalf. Thank you everybody for being so patient. Thank you AIOC for giving us this extra time. Thank you very much. I would like to thank all our judges for being so patient with us. Thank you very much once again. Thank you.
शेयर मत कीजिए डोंट शेयर
Please, please. Please.
अभी शेयर मत कीजिए इंट्रोडक्शन